Yeah. Just showcasing a case that's, that is sometimes once in the blue moon. So all the time, the categorically, this is a cheap case, this is not a cheap case, that discussion was there. And most importantly, the most important learning objectives for any case, that any case may turn into a cheap case also, in a complicated case and ultimately in a cheap case. And whatever, and geographically you see, always that's not the correct one. Sometimes it happens. And that has happened for this case which I'm going to show. This is a traumatic situation here. That my case was along with an HBR and a cheap case at the same time. This is I'm telling because once upon a time while the intervention community, like 5 to 10 years back, was engulfed with very late stent thrombosis and blah, blah things also. At the same time, bleeding was totally undermined or underestimated or categorically ignored. But now, from real-world perspectives, bleeding risk and HBR terminology is like the talk of the town. And why? Because bleeding matters. Major bleeding ultimately leads into a mortality. And that's the biggest thing. If you see the TRACER trial also, and other almost 2.5K HBR patients, there also you see the bleeding has a huge impact on the outcome of the patient. And in fact, just bleeding nowadays, the trials when we are doing the meta-analysis, then we are seeing that bleeding matters just as much as ischemic risk, almost equal in this case. And that has been so. There is a tug of war while doing a PCI, whether balancing between a bleeding and ischemic risk. So it's a tug of war. You have a high bleeding risk patient, you have a high thrombotic risk patient, and how you will manage in between this, that's the biggest thing. And I have found this GIF image is the best one to think of these things in the PCI terminology. So my case, before my case, that how to define HBR, many scores are there, and the cases like this, I have named this case a thriller movie based on a true story. And this is because, in brief, this case was a 75 years female, very frail, and comorbid patients with all sorts of risk factors were there. At the same time, anemic patients, and also EGFR was poor. So ultimately, it has been included by the precise DAPT score or the ARC HBR scores, and it's more than 25 precise DAPT, and also it's meeting the ARC HBR criteria. So it's a HBR case ultimately, and also the patient was an ACS case, so it's an ACS with HBR. The CAG was warranted for this case as the patient has come with a severe angina after prior MI within 7 days, and a procedure was done somewhere in the planet, not in my place. And CAG finding was unexpectedly too much disastrous for this patient. And the further PCI procedure and its aftermath are very much intense to bear. This is the picture of the right coronary artery. Good thing that transradial approach was applied for that case, especially for HBR. We have to go for the transradial approach for safety purpose. But if you see the left side, this is really something horrific here. And in these sort of cases, and you can also understand the calcifications, even angiographically. This is too much up to the whole length of the LAD, and also in the LCX also. So it's made of cement-like things. And also at the same time you see the origin of the LAD. It has got almost a 90-degree torque, and then it has come down. And it is in a calcific environment. That means that even wearing cannot make it straight. So that's the problem there. And if you see the graphic picture there, pretty obvious even without contrast. And what should be the plan for these old 80, 75 years old patients with frail? Surgeon already fled the scene. And sensing the smell of the calcium, and wouldn't be an easy fizzy case for PCI too. So what we need for this calcified, with a calcified environment, this case to do. So you need a shell filled with weapons like balloon-based pulp plaque modifications. You have these weapons, or device-based. These are so far the devices and the balloons you need in your shell to treat this sort of patients. But at that center, unfortunately, all these devices were not there in the shelf. So PCI was attempted with very limited shelf. And they tried hard with repeated escalation of the profile of the NC balloons, and some sort of plaque modification has been happened, but still, dog boarding effects are there. And again and again they have ballooned it, they have done the body wiring, the basic principles to go for these sort of calcific PCIs, whatever they have in their shelves. So they have tried balloon after balloon, and after that, when they have just felt that even though they don't have that imaging there, so they have felt that it is now looks like that we can put a stand there, so they tried to deploy the stand. You can see on the right side, they have tried to deploy a long desk. And this long desk is stuck there. No way out. Angry calcium didn't like its underestimation. Didn't like it. And what has happened? Exhausted operator, gone with the wind. Everything except the undeflated stand, which has been remained there, everything has come out. Incessant calcium, dislodged stand with wear loss in left main and proximal LED, and a part hanging in the aorta. Another hiccup, took some desperate attempts to retrieve the stand, maybe unorthodox, but with good intention. They have wired it beyond the stand, and they have tried to balloon it, but what it causes, so far this is the end of the battle in the primary battlefield with this picture. You see, the stand is much more hanging now, distorted in the middle, and totally stuck in the proximal LED and the left main. Patient was transferred with this hanging metal in left main LED immediately to somewhere else like us. After arrival, immediate observation was that the patient looks pale, hemoglobin percentage drops down to 8.5, and immediate transfusion was given, and patient's ejection fraction, we have reviewed that it's remained the same as it was before, like 45%. Fortunately, there was no more problem within this transfer, and a little bit heart failure was there, and creatinine levels is marginally raised. Team review again was done because even we didn't want to touch that one. Surgeon was speechless with blurred vision. That is not possible. So a perfect HBR case with iatrogenic disaster in left main and a severe calcification. What should be the next move? Chip PCI with HBR, a double blow here. Need meticulous planning, many other issues to keep also in mind. The issues are, we have to have the vascular access, choice of stents, antithrombotic medications, and complexity of the lesion. These are, for HBR, these are the 4 things we have to keep in our mind all the time. And also, we have to go for the high ischemic risk and a balance between high ischemic and high bleeding risk patients for this case. There are lots of trials for these things, I'm going chronologically up to 2023 or with the trials of the stent platform and also trials of the DAPT and durations also. And the short DAPT is possible. So what we have planned, too many hurdles and retrieval of the dislodged stent, living in a den like grizzly. If it works, the next step is to dig the rock with all the modalities in hand. So 2 hurdles there. Frailty, comorbidity, hemodynamics are a huge concern for this patient. And most importantly, KISS to be the only instinct. KISS means keep it safe, simple, and sweet, at least, to make it possible. So journey started again with the transradial approach. We have first done a angiogram, relook angiogram there. And if you see that the stent is still in the same way, a bit much more hanging there and in the aorta. But to me, the most important thing is that the TIMI3 flow was not just lessened there, but it's still TIMI3 flow is there everywhere. So it's like from the PCR online you can see this total stent and guide well loss, how we can start going for this one, like pass a coronary guide wire and try to use a snare and to retrieve the lost stent, because you don't have the guide wire there, and you have the stent is total failure. And if failed that one, then crush the stent, but not for this case. You can't crush it because it is beyond the left main. So it's also another problem. Some way you have to retrieve the stent. Didn't think of wiring, seeing the complex metallic scenario of the left main and beyond left main arena. So I didn't want to go for the rewiring. First is trying to retrieve the stent by a snare, micro snare. So you see, this took the micro snare. Useful retrieval device is the snare. And this snare is different brands are there. We have used the snare, and this is the square snare system we have in our shelf. So initially the 5 millimeter micro snare we have taken didn't work, so took 10 millimeter. And you see that after lots of hurdles, you see the catheter was just retrieving and getting out, and at long last the snare has been able to catch the hanging part. And after catching it, so sweet it is, we have felt at that moment. And then gentle pulling in the neck with controlled traction. You see? And this is coming out without any problem. And the next thing is that the stent material is just beyond the catheter, and snare is just controlling it tightly so that it cannot come out and embolized. And then the whole system has been combed out with the sheath, and the catheter we have taken it out. And you see now within the sheath the stent. And in my hand, the stent material is like this, so much distorted there. So this is the Kalnayak, or the villain. So the villain is there. And then we have gone for the left transradial approach, because right radial we can't go again. So far no apparent harm in pulling the dislodged stent. We have checked it, and we have taken a 6 French XB guide catheter there. What about this LCX? You know, it looks like severe eccentric calcification, but it's not a long segment there. Smell of chaos and complicity there, also in LCX also. And it's a huge system, because it's a dominant system is the LCX there. We have in our lab, fortunately, except laser, except chocolate PTC balloon or orbital, the rest of the armamentariums, we are fit with that shelf. So we are a little bit confident that we can start and we can go on. So plan first for fixing the huge LCX, thinking of the KISS principle, and just finish that one. stable the patient a little bit, and then go on for the LAD. And whenever we have gone there also, it was also a big pain. You see that how much dog bullying there, even in the LCX. The balloon was, even taking the scoring balloon, it was not moving. And as we have tried to make it simple, and it's a shorter segment, it's not a long calcification there, and after that 2.5, 15 balloon crossed 12, inflated apparently well, but stent was not going there. I didn't push that much. I didn't want to record the same scenario as it was before. So what I have done, I pulled it out, and I have started using my old armamentarium, my next level armamentarium, the IVL. So it's a 2.5, 12 IVL. It has been crossed, 30 pulses has been delivered, and after that, you know that it has softened the calcium. And after that, still there is some still dog boning. So after that, we have ballooned it properly with the, now that same day switches, I have tried to deploy it. I have deployed it properly, and it has been fixed out. So LCX has been fixed out. Now comes to the old foe. By this time, enough lesson was learned that this calcium is really, really insistent everywhere. So it is going to be a very sleepless long night to fix the LAD. We have predicted that one. So now the picture is there. Try to take the IVUS catheter in LAD, because we have thought that previously ballooned it so much that maybe IVUS catheter can be crossed, but IVUS catheter was not crossed well. So took the balloons again. I have ballooned it again and again after NCE and scoring balloon ablation, plaque shifted distally. You see, which I didn't want for this case. The distal embolization by any means. So that's why I wanted to avoid even the rotablation initially for the first as the primary one, because the distal embolization in the both system is really, really troublesome for this case. On the table, the hemodynamics patient will be crushed. So, but it happens here also. There's some plaques has been, and distal LAD has been blocked there. Patient started screaming with angina. And then I have took the same IVL balloon which has inflated in LCX. It has gone a little bit, you see, here up to there. I have given 20 pulses there. And when at the 60th pulse, then the IVL balloon has been ruptured. So you have to put it out. I couldn't put that picture there. And then I have gone for my old best armamentarium, that means the rota. So taking the old wine, the rota, to make the procedure, Tripsy rota. So taken the rota about 1.5 and with very, very short run and picking motions with there with the 1.5 bar, then we have been able to do the IVUS, and IVUS has shown switch cracks there. It has also both the rolls of the IVL and the rota both has given these cracks and make us happy. And after that, the stenting was easier. Middle it is stented by 2.75 18 millimeter DES. I didn't want to take a long stent for this case. And then 3 into 18 in the proximal LAD, and for the osteoproximal LAD 3.5 15 DES. And as fortunately, because of this 90-degree angle, you didn't need to go beyond the ostium to the left main. That was also a very good thing for this patient at least. And you see the final IVUS and the final picture. Ultimately, I started just playing violin after a long, hard effect or attack. So you see, it is beautiful now. And antiplatelet therapy here for this HBR case, I have given the DAPT for 3 months to 6 months. I will continue it. So every day I am learning. In calcium-loaded coronary, if IVUS catheter cannot cross, take rota. It's a wise man's word. Hemodynamics, frailty of the patient, faster coming out with success, sometimes may drive one in a more complex path, which has happened initially. sometimes feel that imaging catheter should be a bit stronger. I want it because IVUS catheter is so fragile that you can't go it with that. And IVL and rota are complementary, not antagonistic or each other worse. It's both are necessary for everything. And calcium in coronary is very much unpredictable by behavior, which we have seen by seeing that case. Thank you very much.